Really delighted today to have a few professors. So we have Professor Santanu Tripathi sir as moderator. We also have Professor Susanta Bandyopadhyay sir as moderator, and we have our own president, Professor T K Mondal sir today. And we are really thrilled to have Professor Chatterjee sir, who needs no introduction. And on behalf of Indian Pharmacological Society West Bengal chapter, I welcome you, sir. And at the onset, I just also want to thank our technical team, InnovoCare E-Academy, for giving us this wonderful opportunity to have our first master class on pharmacology and therapeutics. And this, I think this is after a long time, Indian Pharmacological Society of West Bengal chapter got the opportunity to have this type of web meeting. And now may I request our moderator, Professor Santanu Tripathi sir, to introduce the topic, and then we will go to the lecture of Dr. Rabindranath Chatterjee sir. Over to Tripathi sir.
Good evening, everybody. And thank you very much, Dr. Samajdar, for having organized this wonderful session today. And it's quite a long time, and particularly because, as we know, that the COVID pandemic has, so to say, disrupted all spheres of life, and academics is also no exception, as we know. But then out of all bad things of pandemic, we also have learned this new order of online learning sessions, and which has almost coming to become a norm rather than exception now. And most of us gradually are becoming used to it. And today we are going to start with, I think Dr. Shambo has promised that there will be a series of such master classes. And to start with, the topic is this anti-arrhythmic drugs, or rather more correctly, pharmacology of cardiac arrhythmias. And to deal with this otherwise challenging topic or challenging subject, we have none other than Professor Rabindranath Chatterjee, whom we all know in West Bengal and also in the whole of the country, that he is a great teacher of our times. He is always very well admired by all his students because of his great skill in teaching. And Dr. Rabindranath Chatterjee today will be speaking on pharmacology of cardiac arrhythmias. I am sure all of us who have assembled here today, I find there are almost, at least what we find in this list, not less than say 60 people who have joined here. And I am sure there are other mechanisms also, other ways also, that many people who are not being seen here, but through Facebook and other techniques of online transmission, many more people are actually going to listen to this lecture today by Professor R.N. Chatterjee. So without standing between a great lecture today and all the listeners, I would rather stop here and request Professor R.N. Chatterjee to please come up and start your talk. Professor Chatterjee, please. Over.
Good evening to everybody. My happy New Year's to all the IPS members. Now, at the outset, I express my sincere thanks to Professor T K Mondal and Dr. Shambo Samajdar, who requested me about 1 month back to give a lecture on some topic in pharmacology. Now, I selected this topic, cardiac arrhythmia, because as Professor Tripathi told, it's a challenging topic and one of the most complicated topic in the subject of pharmacology. So I selected this topic. But I don't know how much I'll be able to satisfy others by online lecture. But still, as Santanu Tripathi has told, it is a new experience. And I, I admit this is my first experience as a teacher to give online lecture. Let me see how much we can satisfy and we can adjust with these whole surroundings in this COVID atmosphere. So with this few topic, now I'm going to start my topic. Now my topic is the pharmacology of cardiac arrhythmia. The first thing is, what is cardiac arrhythmia? Now, cardiac arrhythmia is a clinical condition where there is abnormality in the heart rate and rhythm. Why? It is due to alteration in impulse generation or impulse conduction or both. Now, there are certain factors which can precipitate this cardiac arrhythmia. What are the factors? The factors are myocardial ischemia, then myocardial hypoxia, mechanical injury, electrolyte imbalance, especially hypokalemia, then alteration in autonomic activity, and some drugs like adrenergic drugs, digitalis, antiarrhythmic drugs, some quinolones like gatifaxacin, then tricyclic antidepressants, and then drug interaction, erythromycin with cisapride or estemizole. Now, to understand the genesis of cardiac arrhythmia and the mechanism of action of antiarrhythmic drugs, we should have some knowledge about the electrophysiology of heart. Otherwise, it is difficult to understand the topic. Now, see, the heart has got two types of fibers. Two types of fibers are there in the heart. What are the two fibers? That is autonomic fibers and non-automatic fibers. Now, automatic fibers, it is present in the SA node, AV node, and His-Purkinje system. And what is their peculiarity? They undergo spontaneous diastolic, slow diastolic depolarization and can generate their impulse without any external stimulus. But non-automatic fibers, see, present in the atrial and ventricular muscles, and their RMP remains steady and they do not undergo slow diastolic depolarization and cannot generate impulse of their own without any external stimulus. Now come to the action potential. Now in the heart, we see there are two action potential. One is slow action potential, another is fast action potential. Now slow action potential, it is observed in SA node, AV node. That is where we get the pacemaker of the heart. And fast action potential observed in His-Purkinje fibers, atrial and ventricular muscles. Now in the next slide, you will see all the cardiac action potential in all, whether slow or fast, there are 5 phases. That is phase 0, phase 1, 2, 3, and 4. But there are some differences in the slow and fast action potential. Now see, there are 3 I have given. Here is slow action potential in SA node. This is fast action potential in Purkinje fibers. This is fast action potential in the ventricle. Now first is the action potential in the Purkinje fibers. Clearly, you can see the 5 phases. See phase 0, phase 1, that is the rapid repolarization. Then you see the phase 2. Phase 2, that is the plateau phase, calcium influx occurs. Then the phase 3, phase of repolarization, followed by again phase 4, continuous depolarization. But one thing you notice that in the phase 0, sodium influx is the main point. Come to the first action potential in the ventricle. Everything is same, like this one, but there is no slow diastolic depolarization. Phase 4 is stable. Now come to the slow action potential. Here you see there is phase 0, but there is no 1 and 2. 1 and 2 is indistinguishable and it is merged with phase 3. Merged with phase 3. And phase 4, see, it is going very slow. And this phase is slow, and here calcium influx is the main depolarizing current. Here it is sodium in first action potential, but here it is. Now come to the clinical significance of this knowledge. So you see, in slow action potential, influx of calcium is the main depolarizing current. But in fast action potential, influx of sodium is the main depolarizing current. The slow action potential is observed in SA node, AV node. So calcium channel blockers are effective only in supraventricular tachyarrhythmias, but not in ventricular tachyarrhythmias. This is very important point from clinical point of view. The why the calcium channel blockers are effective in supraventricular but not in ventricular. This is the answer. The in slow action potential, influx of calcium is the main depolarizing found, which is found in SA node and AV node. But fast action potential, sodium is the main. That's why not affected, and ventricular tachyarrhythmias are not affected. Now come to the genesis of cardiac arrhythmia. Already I told it may be due to alteration in the impulse generation or alteration in the impulse conduction or both. Let us take number 1, alteration in impulse generation. It may be, first thing is alteration in normal automaticity, where mainly in the SA node, maybe also in the AV node, but main thing is SA node. Why? Because of either increased sympathetic activity or vagal activity or intrinsic some disease or drugs or electrolyte imbalance, and may lead to sinus tachycardia, sinus bradycardia, sixth sinus syndrome, ventricular tachycardia. The second one, there may be appearance of abnormal automaticity where in atrial and ventricular muscles mainly, or in Purkinje fibers. When the RMP becomes relatively positive due to some because of activation of beta-adrenergic receptors or stretching of the cardiac myocytes or hypokalemia, and may lead to ectopic beats to form an ectopic focus. Number 3, this is triggered activity or after depolarization, means secondary depolarization triggered by an action potential. That's why one action potential is essential to produce this after depolarization. So it is called triggered activity. It may be early after depolarization or delayed after depolarization. In early after depolarization, you see the depolarization occurs before the repolarization is complete. But in case of DAD, after the repolarization is complete. That is the difference between EAD and DAD. And why it is? It occurs due to abnormal influx of calcium into cardiac myocytes during or immediately after phase 3 of action potentials. Now, where it is observed, now EAD can develop when the heart rate is slow, in presence of hypokalemia, hypoxia, acidosis, plus the antiarrhythmics which can prolong APD. Torsades de Pointes is an example of EAD. And DAD occurs when the heart rate is, see, rapid and intercellular calcium concentration is high, like myocardial ischemia, digitalis intoxication, adrenergic stress. May lead to coupled extrasystoles, pulsus bigeminus, supraventricular and ventricular tachycardias. Now, alteration in impulse conduction. It may be number one, see conduction block. Now, conduction block, it may be incomplete, may be complete conduction block in the AV node or his bundle branch block, leading to due to vagal influence or myocardial ischemia, leading to partial, that is first degree, second degree heart block, or complete, that is third degree heart block. Now come to re-entry or circus movement phenomenon. Circus movement phenomenon, it is the most common phenomenon. In the genesis of cardiac arrhythmia, 80 to 90% of case is due to re-entry. Now for re-entry, you will see one region of unidirectional block and slow conduction of retrograde impulse through this blocked area are essential. I am showing you the slide. See, one unidirectional, one block is essential, and the movement of this retrograde impulse should be slow. This is essential to generate this here. Now, this re-entry may be of two types. One is anatomically defined re-entry. Another will be, I will discuss later on, functionally defined re-entry. The anatomically defined re-entry, here you see the phenomenon occurs, re-entry occurs along an anatomically defined pathway. Fixed large circuit, it is not small circuit, large circuit around an anatomical barrier. So anatomically defined, large circuit, anatomical barrier. Classical example is Wolff-Parkinson-White syndrome and others, atrial flutter, ventricular tachycardia, PSVT are the other examples. Here I have given the picture of Wpw syndrome. See, this is the pathway, abnormal path, the abnormal path, rapidly movement. Now this re-entry occurs in Wpw syndrome. Second one is functionally defined re-entry. Here is, see, no definite anatomical pathway and occurs in short circuits anywhere in the atria and ventricles around a functional barrier. There is no anatomical barrier which is impacted or injured or refractory myocardium and mainly observed in ischemic heart disease, atrial fibrillation, ventricular tachycardia, ventricular fibrillation are the examples. Now, just to discuss, see, normally what happens? One impulse originating in SA node, then AV node passes to Purkinje fibers, then it is coming this side, it is going and they are meeting together and they collide together and terminates. It is normal. But in this case, it is going this side, then coming here, but this is getting blocked, so cannot pass. But now this impulse, when it is coming, then it is now in the stage when it can pass through it, and it is but passing very slowly, and then it is going on, and re-entry occurs. Now, how the re-entry can be abolished then? Pharmacologically, how can? we can abolish it by converting this one-way block to two-way block, or by removing this one-way block by improving the conduction. By that way, we can abolish re-entry. Now, clinical types. Now, before going to the drugs, we have to know the clinical type, because all the indications we will discuss on the basis of this cardiac arrhythmia. So, we have to know the clinical types of cardiac arrhythmias. Now, on the basis of genesis, cardiac arrhythmias may be Bandyopadhyay on Bandyopadhyay, that is failure of impulse generation in SA node, or failure of impulse conduction through AV node and bundle of His, and includes sinus bradycardia, sick sinus syndrome, partial or complete heart block. Now, there may be tachyarrhythmias. Now, tachyarrhythmias may be due to impulse generation, increased or abnormal automaticity, or triggered activity, or re-entry. And it may be supraventricular, it may be ventricular. Supraventricular, sinus tachycardia, atrial excess systole, atrial flutter, atrial fibrillation, atrial flutter, PSVT, Wpw syndrome. Ventricular, ventricular excess systole, ventricular tachycardia, ventricular fibrillation, torsades de pointes. And it may be digitalis induced supraventricular and ventricular arrhythmias. Now come to the drugs. Now, Vaughan William and Singh classification in 1969. There he classified class 1, that is sodium channel blockers, that is membrane stabilizing agent. It go 3 groups, 1A, 1B, 1C. Now, 1A causing moderate phase 0 depression. Drugs are Quinidine, Procainamide, Disopyramide. Second one, minimum phase 0 depression like Lignocaine, phenytoin, mexiletine, tokenide, causing marked phase 0 depression like flecainide, encainide, indicanide, etc. Now, class 2, that is beta-adrenergic blockers. The beta-adrenergic blockers, mainly propranolol, esmolol, sotalol. Others rarely used. Now, potassium channel blockers, class 3. That is, they prolong APD. Amiodarone is the main drug. Now, newer drugs have come. Dronedarone, Varnacalan, Bretylium is age-old drug. Sotalol also age-old drug. Now, ibutilide, dofetilide, they have come in the picture, sometimes used. Now, calcium channel blockers, class 4, that is mainly verapamil and sometimes diltiazem, very rarely Bepredil. Now, these two have been added, but they were not originally in Vaughan-Williams classification. That is class 5, we have added potassium channel openers, that is adenosine, and some miscellaneous drug like digoxin, atropine IV, magnesium sulfate IV, isophenylene labdi. So these two other than Vaughan-Williams classification. Now let us take number 1, quinidine, age-old drug. And quinidine was introduced as antiarrhythmic agent in 1920s accidentally while treating a patient of malaria by quinine. It was an observation, and by this observation, gradually it came into picture, and 1920s introduced an antiarrhythmic. Obtained from cinchona bark, and it is an D-isomer alkaloid of quinine. Now, its antiarrhythmic effect is it blocks the fast sodium channels mostly in the activated state, and recovery is slow, that is 3 seconds, and prevents influx of sodium in the phase 0. It also blocks the delayed rectifier potassium channels and L-type calcium channels in high concentration. Now, what will be the effects Now, to know, remember the effects, I always try to keep the 5 or 6 points so that we can categorize like these 5 points like automaticity, excitability, membrane responsiveness, then conduction velocity, ERP and APD, ECG, net effect. If we concise ourselves with these 5 or 6 points, then we can remember easily. Now, automaticity, decreased automaticity in Purkinje fibers and active foci. Excitability, decreased excitability in atrial and ventricular muscles and Purkinje fiber. See, everywhere SNOD is most affected because SNOD is calcium is the main ion, not the sodium, and it is blocking the sodium. Now, membrane responsiveness, moderate depression. Conduction velocity is directly proportional to membrane responsiveness. So as it is moderate, here also moderate. So moderate depression of conduction velocity. It prolongs the ERP, APD and ERP, APD. This is important point in cardiac electrophysiology of the heart and antiarrhythmic drug. ERP, APD has to be increased. And ECG, PR, QT intervals prolonged, QR is complex. And what is the net effects? Ectopic impulse formation decreased. Limits spread of the impulse and abolishes the re-entry by converting one-way block to two-way block. Now see the picture. Now in this picture you can see that there is moderate depression of the phase 0. Then this is APD, ERP, all prolonged. And automatically conduction velocity also will be increased. Now come to the other than this, some other effects are there which are clinically important. Now it exerts vagolytic or atropine-like effect, which has got importance that it increases the conduction velocity and ERP decrease in AV node and may cause important thing is paradoxical tachycardia in atrial fibrillation and flutter. So how we can prevent it? We can prevent it by prior digitalization. Now it decreases myocardial contractility and may precipitate heart failure. So in heart failure patient should not be given. It can block alpha-adrenergic receptors, may cause hypotension. We should be careful about it. And skeletal muscle contraction decreased by direct action. So if it is given along with skeletal muscle relaxation, the action may be prolonged. And uterine contraction, so in pregnancy, you should not avoid it. It increases uterine contraction. Now, quinidine therapeutic use, it is rarely used, but it is a broad spectrum anti-arrhythmic agent and useful for all short-term and long-term treatment, almost all types of cardiac arrhythmia. But because of toxicity and availability of better drugs, nowadays it is rarely used in atrial fibrillation, atrial flutter, to restore the sinus rhythm, to ventricular tachycardia, to prevent the recurrences, and ventricular fibrillation as prophylaxis. But it is not preferred in digitally induced cardiac arrhythmia because of high toxicity. Now, regarding the adverse effects, it has got low therapeutic index, very important clinically. And 1/3 of the patient experience immediate adverse effect and requires discontinuation. Regarding the GIT side effect, most common side effect is diarrhea, 30 to 35% of patients. And CVS, hypotension, paradoxical tachycardia, and may precipitate heart failure, ventricular tachycardia, and marked QT prolongation and torsades day pointis. High doses, it can produce synchronism in high dose, and sometimes it may produce hypersensitivity reactions like fever, anaphylactic reactions, thrombocytopenia, rare but serious reaction due to formation of drug platelet complex and antibody formation against platelets. Now come to the second one, that is procainamide. It is the amide derivative of cocaine. Cocaine is no local anesthetic, but it is not given because it is not orally effective, rapidly destroyed, and CNS effect. But its antiarrhythmic effects are similar to quinidine, but it has got some difference. What are the differences? Now it has got less vagolytic action, no alpha-adrenergic blocking action, less myocardial depression, and less fall in BP. Um, Now, regarding its pharmacokinetics point of view, clinically important, it is metabolized by N-acetylation, and this is genetically determined. That is, there is slow acetylators and rapid acetylators. And it is observed that one important problem with this one, Essely-like syndrome is more common in slow acetylators. Now, it is sometimes used for IV for acute termination of atrial fibrillation or atrial flutter or ventricular tachycardia and ventricular fibrillation. But long-term therapy is avoided because of this Essely-like syndrome. Now, regarding the adverse effects, it is better tolerated than quinidine, but may cause nausea, vomiting, hypotension. Again, QT prolongation and torsades day point is, and Essely-like syndrome. 25 to 50% of patients on chronic therapy when it is more than 6 months, and more common in slow acetylators. But it is reversible on discontinuation. So we have to inform the patient that as soon as you develop something like this, you please inform so that the drug can be stopped and the symptoms can be reversed. Now come to the disopyramide, another class 1A antiarrhythmic. Now this one also, antiarrhythmic effects are similar to quinidine, but differs from, it has got marked cholinergic effect, marked myocardial depression effect, so avoided in heart failure, no alpha-adrenergic blocking productive, but it causes less depression of conduction, so prolongation of PR and interval widening of PR is less marked. Now, sometimes used orally as an alternative to quinidine or procainamide for chronic prophylaxis like atrial fibrillation or atrial flutter to maintain the sinus rhythm after cardioversion, ventricular tachycardia or ventricular fibrillation to prevent the recurrences. Regarding the adverse effect, it is again better tolerated than quinidine, but may cause significant myocardial depression and may precipitate heart failure and may cause torsades de pointis. And anticholinergic effects are marked. Side effects are marked: dryness of mouth, blurring of vision, constipation, retention of urine, precipitation of acute congestive glaucoma. Now, lignocaine, coming to the 1B antiarrhythmic. Now, lignocaine, local anesthetic, very popular local anesthetic. Now, it blocks the sodium channels both in activated and inactivated, but mostly inactivated. By see difference, here it is rapid recovery, 0.1 second, and possibly also increases the outward movement of potassium by activating delayed rectifier potassium channels. Mainly affects ischemic, rapidly firing tissues in Purkinje fibers and ventricle, but not, see, very important point, clinical point, SA node, atrium, AV node are little affected because atrial action potentials are very short and sodium channels remain in inactivated state for a brief period, so gets time for recovery. So lignocaine is not effective in supraventricular tachycardia. It is effective only in ventricular tachycardia, particularly in ischemic after myocardial ischemia. Now, again, the effects are, I have categorized under the same heading: automaticity, decrease automaticity, C, Purkinje fibers, ectopic foci in ventricle, not SNOD or atrium. Decrease excitability, Purkinje fibers, ventricle. Minimal depression of conduction, but here another important point, does not worsen AV block and may improve the conduction in mode and ventricle. That's why in digitally induced cardiac arrhythmia, it is the drug of choice. So in digitally induced cardiac arrhythmia, Lignocaine to combat this ventricular tachycardia or ventricular fibrillation, drug of choice. Now, ERP, APD, here is the difference. In case of Quinidine, you have seen lengthening, prolonged. Here it is C, just opposite, shortening of APD and ERP. But in Purkinje fibers and but see, APD is more shortened than ERP, but ERP APD ratio is increased, which I told that in the pharmacology of cardiac arrhythmia, ERP APD must be increased. See the slide here again. There is minimal depression of phase 0. Then this is shortening of the APD, shortening of the ERP. It is the normal. This is the after Lignocaine. Now come to Lignocaine ECG, not the PR QT intervals, QR's duration are minimally affected and inhibits ectopic impulse formation in ventricles. Remember this point, ventricles, abolishes re-entry in ventricles. And regarding the additional effects, no vagolytic effect, less myocardial depletion, so can be used in failing heart, less fall in BP. Regarding the pharmacokinetics, it is well absorbed after oral administration, but undergoes extensive fast metabolism in liver, so not effective orally. It is administered only IV. Even after giving IV, what happens? It is rapidly distributed to peripheral tissues, and distribution half-life is only 8 minutes. So after a loading dose, action remains for 10 to 20 minutes, and dose has to be repeated every 10 to 20 minutes or administered by continuous IV infusion to achieve the desired effect. This is another clinically important point. Now, Lignukin is a popular antiarrhythmic and IV only in, used IV only, and where? In ventricular arrhythmias, or like acute termination of ventricular tachycardia, ventricular fibrillation after myocardial infarction, or cardiac surgery in ICU. And drug of choice is digitally induced in cardiac arrhythmias. The adverse effects mainly CNS, nystagmus, tremor, dysarthria, etc., but least cardiotoxic, class 1 antiarrhythmic. Now, phenytoin, another antiarrhythmic under this group. It is a popular anti-epileptic drug. It is just like Lignocaine. It blocks the sodium channels in inactivated state with rapid recovery. And antiarrhythmic properties are similar to Lignocaine. No autonomic activity, myocardial depression are less than Quinidine, but it is reserved for treatment of digitally induced ventricular arrhythmias as an alternative to Lignocaine. At present, not much favored. The mexiletine, another drug, it is also orally effective analog. That is the advantage, orally effective. But what pharmacological action, same as Lignocaine. Sometimes used orally, IV, in post-myocardial ventricular arrhythmias. Sometimes. And for orally used, chronic prophylaxis of ventricular ectopics and ventricular tachycardia. But it has got narrow therapeutic index, and this limits its usefulness. And regarding the adverse effects, nausea, vomiting, tremor is the early sign, ataxia, blurring of vision, and serious side effects, bradycardia, hypotension, AV block. Now come to the 1C. Class 1C antiarrhythmic, that is Procainamide prototype drug. Here it is most potent sodium channel blocker, and it blocks the sodium channel mostly in the activated state. Lignocaine was inactivated state. It is activated state and very slow recovery. Lignocaine was very rapid recovery and slow recovery, 11 seconds, longest recovery time. It has got the longest recovery time. Also blocks delayed reactive potassium channels and L-type calcium channels. Now, effects are, see, marked depression of the membrane responsiveness and marked depression, slowing of the conduction velocity. This is directly proportional always. Membrane responsiveness, conduction velocity, directly proportional to each other. ERP APDC, minimum effect. And the effect is most prominent on this Purkinje system and accessory pathway in WPC random. Supraventricular, not much. Now see the effect. See, marked depression of this one. And but ERP APD is not much changed. It is very clear. Now, therapeutic use, it is really reserved for the patients with refractory ventricular extrasystoles or life-threatening sustained ventricular tachycardia without any history of myocardial infarction. If there is myocardial infarction history, then toxicity increase and it damage the heart. So not contraindicated. There should not be history of myocardial infarction. And sometimes to maintain the sinus rhythm in resistant cases of recurrent atrial fibrillation and Wpw syndrome. Adverse effect, it has high pro-arrhythmogenic potential, and serious drawback is torsades de pointis. And regarding the other effects, most common is blurring of the vision, and it is a cardiac depression, so may precipitate heart failure. Now, if you compare the effects of class 1A, 1B, 1C together, see now class 1A plus 1B minimal depression, 1A moderate depression, 1C marked depression. Now 1A ERP APD prolonged, 1B ERP APD shortened, and 1C not much change. So these are the, with one diagram, you can clarify the effect of 1B, 1A, 1B, 1C. Now beta blockers. Beta blockers, antiarrhythmic effects of beta blocker, class 2, its antiarrhythmic effects are due to competitive blockade of the beta receptors, and thereby it blocks the effects of catecholamines on the heart. Now, what are the effects? Again, same automaticity, decreased automaticity, SA node, Purkinje fibers, ectopic foci. When increased by adrenergic stimulation, mainly excitability, decreased excitability in ventricles, membrane responsiveness only in high concentration, conduction velocity, decreased conduction velocity in AV node, ERP APD, prolonged APD, ERP and increased ERP APD in AV node, and ECG, PR interval, QT, all are not much altered. Now, here also see the automaticity decreased. Now, the blue, see, it is prolonged. Phase 0 depression, little bit, very rare. APD, ERP, slight changes. When is automaticity is decreased, and this is decreased, automatically conduction velocity decreased. Now, beta blockers are useful both in tachyarrhythmias induced by catecholamine excess, like stress, anxiety, exercise, hyperthyroidism, pheochromocytoma after halogen anesthesia. It is very useful in supraventricular, less useful in ventricular arrhythmias. Now, beta blockers use supraventricular uses are sinus tachycardia, premature extrasystole, atrial fibrillation and atrial flutter to control the ventricular rate in PSVT and WP syndrome. Beta blockers alone or in combination with quinidine is given. Other therapeutic uses may be for rapid control of ventricular rate during surgery in atrial fibrillation AP during surgery with halothane anesthesia. Esmolol is the drug of choice. The ventricular arrhythmia like premature ventricular complexes and prophylaxis of polymorphic ventricular tachycardia induced by emotion or exercise. Chronic prophylaxis, it is from congenital long QT, not acquired. In congenital long QT syndrome, nadolol is sometimes given for prophylaxis. And next is digitally induced tachyarrhythmias, both supraventricular and ventricular. Beta blockers may be used but not preferred because they produce bradycardia and increase the AV block. So we have to be cautious. We have to see first whether there is an AV block or not. If there is no AV block, then we can give. Otherwise, lignocaine is preferred. Now come to the class 3. Class 3 antiarrhythmic, that is amiodarone is the prototype drug. Amiodarone, here amiodarone is an iodine containing compound and is related to thyroxine. Now, it is an unique broad spectrum longest acting, 3 important points, longest acting antiarrhythmic agent. This comes usually in the MCQ, the broad spectrum longest acting, and it is mainly a potassium channel blocker, and blocks outward movement of potassium during repolarization. Now, another regarding amiodarone, it possesses action of all the 4 classes of antiarrhythmic agent. See, blocks sodium channels in inactivated state with relatively rapid recovery like lignocaine, class 1. Blocks beta-adrenergic receptors, class 2. Blocks potassium channel, class 3. Blocks calcium channel, class 4. The effects are automaticity, decreased automaticity in SA node and ectopic foci in most tissues due to inhibition of calcium current. Membrane responsiveness, decreased membrane responsiveness due to blockade of sodium channels. Conduction velocity in AV node decreased. ERP-APD increased, and delayed repolarization. This is the most important thing, delayed repolarization by potassium channel blockade. Now see the effect. Phase 0, not much, but see the phase of repolarization, APD, ERP is prolonged because potassium channel is blocked. Now, regarding the pharmacokinetics, clinically important point is we should not hurry up. It may take slow onset of action 2 to 3 days to several weeks to produce the effect. But after IV, each action starts rapidly, but orally, it takes 2 to 3 days to several weeks. So we should give time to get the effect. Another thing is, it accumulates in the muscles and fat, from which it is slowly released and metabolized by liver microsomal enzyme. That is, it is very extremely slowly eliminated. That is why longest action, longer duration of action, plasma T-half is 3 to 8 weeks, longest. Now, regarding the therapeutic use, it is a broad spectrum and most effective antiarrhythmic agent, and a wide range of ventricular and supraventricular tachyarrhythmias. Now, like life-threatening recurrent ventricular tachycardia or ventricular fibrillation resistant to other drugs. And IV it is given. Refractory supraventricular tachyarrhythmia like AFL or PSVT to maintain sinus rhythm. Chronic prophylaxis of almost all arrhythmias except torsades de pointes, and digitalis induced arrhythmias. And prophylactically, it is used to reduce cardiac arrhythmias in post-myocardial infarction patients. And lastly, Wpw syndrome. Side effects, it has got both cardiac and extracardiac. The cardiac pro-arrhythmogenic potential is relatively low. Achha. Cardiac effects, bradycardia, heart. One important point here, see, QT interval is prolonged, but the risk of developing torsades pointes is low. That is to be noted, that though the potassium channel is blocked, but the risk of torsades de pointes is low. Regarding the extracardiac effect, nausea, vomiting, then the peculiarity for this drug is pulmonary fibrosis, bluish discoloration of the skin and photosensitivity, corneal microdeposits, peripheral neuropathy, and hypothyroidism or hyperthyroidism because of relation with iodine-containing compound and relation with thyroxine. Now, regarding the other drugs, like newer drug, dronedarone, analog of amiodarone without iodine atoms. So what happens? It is similar to amiodarone, but adverse effects like hypothyroidism, hyperthyroidism, pulmonary fibrosis are lacking. But it has got another important adverse effect. It may cause severe liver injury. So monitoring of liver function is needed. And used to maintain sometimes to maintain the sinus rhythm or control ventricular rate in atrial fibrillation. The Bharnakalan, same as amiodarone, but adverse effects are less and use IV in atrial fibrillation to restore sinus rhythm. The bretylium is another age-old drug, adrenergic neuron blocker used for hypertension, but it has got additional class 3 antiarrhythmic property. It is a potassium channel blocker and prolongs APD, ERP in most of the cardiac tissues and rarely used in refractory post-myocardial life-threatening ventricular tachycardia or ventricular fibrillation in ICU. And important side effect is postural hypotension. Chronic use is not advised. Now, ibutylide and dofetilide, they are selective potassium channel blocker. They do not block the calcium channel, not beta blocker or sodium channel. So they are pure class 3 antiarrhythmic. Is another MCQ question. The pure class 3 antiarrhythmic is ibutylide and dofetilide. Now, prolonged ERP and APD in all cardiac tissues, and ibutylide is rarely used IV in atrial fibrillation. It is used IV. Ibutylide orally not effective IV, but dofetilide can be given orally and in atrial fibrillation or atrial fibrillation. Most important adverse effect is again torsades de pointes. Now, calcium channel blocker, that is group 4. Verapamil is commonly used. It blocks L-type calcium channels and delays the recovery of calcium channels. It mainly affects slow calcium potential channel in SA node and AV node. Already I discussed in the electrophysiology of heart, where influx of calcium is the main depolarizing current. Does not affect fast action potential in atrial, ventricular muscle, or Purkinje fiber because influx of sodium, not the calcium, is the main depolarizing current. So, calcium channel blockers are useful only in supraventricular tachyarrhythmias, not in ventricular arrhythmias. Now, effects are automaticity. Again, decrease automaticity in SA node and AV node, and heart rate is reduced. Membrane responsiveness slows the rise of action potential at phase 0. Conduction velocity, decrease conduction velocity in AV node. ERP-APD increased in AV node and AV nodal block. ECG VR interval increased. Now you see the response. This is the normal one. Now after giving this thing, see automaticity slope is going there. action potential is growing very slow, and repolarization phase is prolonged. That is the effect of calcium sonar on the electrophysiology of the heart, and it reduces ventricular rate in atrial fibrillation and flutter and terminates PSVT. Now, what are the therapeutic uses? Main important use is PSVT. For rapid termination of PSVT, verapamil is administered IV, 5 milligrams slowly over 2 to 3 minutes. For prophylaxis, can be given orally. Next is to control ventricular rate in atrial fibrillation and atrial flutter, 5 to 10 milligram per hour till response is obtained. For chronic therapy, it can be administered orally. Now, the group 5, that is adenosine. The adenosine is a naturally occurring purine nucleoside. It is an endogenous substance formed as an end product of ATP. It exerts rapid, that is within 10 to 20 seconds, but very short lasting, again 10 to 20 second antiarrhythmic action. The basic point is it is a potassium channel opener. The mechanism of action. Now, when adenosine is given, adenosine binds to G protein coupled adenosine A1 receptor in atria, AC node, AV node, not ventricle, activates acetylcholine sensitive potassium channels, leading to efflux of potassium. There will be hyperpolarization. What will be the effects? Automaticity, decrease automaticity in SA node and decrease sinus rate. Conduction velocity, decrease conduction velocity in AV node. ARP, increase ERP in AV node and shortening of APD in atria. As a result will be what? Increased AV block and prevents re-entry of impulses involving AV node. PSVT is terminated. Now, each actions are specific for the atria, SA node, and AV node. No effect on ventricles, as there are no adenosine-stimulated potassium channels in the ventricles. Now, regarding the pharmacokinetics, the adenosine has a very short half-life, about 10 seconds, because and duration of action is very short. Why? Because it is rapidly taken up by the tissues, including RBC and endothelium, and metabolized by adenosine deaminase to 5-MP and inosine. Now, it is the only drug which is administered as a rapid IV. In pharmacology, probably you will not see formerly dioxide also used to be, but now it is not used. So this is the only drug which is used very rapidly in the central vein. Otherwise, the drug will be eliminated before it reaches the heart. This is to be remembered. Now, what are the therapeutic uses? Drug of choice for acute termination of PSVT, including AV nodal reentrant arrhythmias. Administered, again I am repeating, rapidly IV as bolus dose, and sometimes used to produce controlled hypotension during surgery or during diagnosis of coronary artery disease, for brief coronary artery dilatation, for diagnostic and interventional procedures. Rare cases of DAD-mediated ventricular tachycardia. The adverse effect, transient asystole, less than 5 seconds. In fact, this is the therapeutic goal. And flushing due to vasodilatation, dizziness, another is bronchospasm. And dyspnea, chest pain, hypotension, this is adenosine receptor, but side effects are short-lived, and this is an advantage. Digoxin, another age-old drug, it decreases the conduction velocity, increases ERP in AV node, that increases AV block and reduces ventricular rate. Now, it is used to control the ventricular rate in atrial fibrillation and flutter prior to quinidine therapy or alone. May be used to control BF, but it is contraindicated in presence of heart block or ventricular tachycardia, because in them may lead to ventricular fibrillation. Atropine sulfate, potent anticholinergic, blocks M2 receptor. It antagonizes the effect of acetylcholine on SA node and improves AV conduction. So, may be used IV in the treatment of sinus bradycardia or partial heart block while waiting for pacemaker. Magnesium sulfate, after IV administration, it acts as a CVS depressant and it can be used in digitally induced cardiac arrhythmia. Main thing is it is used in Torsades de Pointes, both congenital and acquired long QT syndrome administered IV. The isoprenal in IV, again sympathomimetic, potent, sometimes used in partial or complete heart block while waiting for implantation of pacemaker, also used in Torsades de Pointes. Now come to the treatment line of treatment of cardiac arrhythmias. Now, cardiac arrhythmia can be treated by two ways: non-pharmacological methods and anti-arrhythmic drugs. The non-pharmacological method, Valsalva maneuver, DC cardioversion, pacemaker, electrical defibrillation, implantation of implantable cardioreverter defibrillator, radio frequency ablation. Now, first decide whether treatment is required or not. If required, then decide whether it can be treated by non-pharmacological methods or antiarrhythmic drug. If the answer is favor of antiarrhythmic, then antiarrhythmic drugs are selected on the basis of the clinical type, possible mechanism underlying the arrhythmia, the range of antiarrhythmic activity and pharmacokinetic profile of the drug, risk-benefit ratio, aim of therapy, whether acute termination or chronic prophylaxis, and presence of structural disease of the heart failure, defect in conductive system, long QT interval, liver or renal function, enlarged prostate, glaucoma, pulmonary disease, bronchial asthma, etc. And facilities available, whether it is in ICU, trained physician, health personnel. Now, in general, sinus bradycardia we treat by injection atropine, IV. Sinus tachycardia, treat the cause, anxiety, like thyrotoxic, etc. If severe, then propranolol or metoprolol. But one thing, see, in heart failure patient, heart rate is increased. We should not give beta blocker. You treat the patient with the treatment of heart failure, not beta blocker. Be remember. Now, next is atrial excess treat the cause. Excess caffeine, alcohol, nicotine should be avoided. If severe, then propranolol or disopyramide. Atrial fibrillation or atrial flutter. Acute therapy, DC cardioversion is the treatment of choice nowadays. Alternatives not available, then propranolol, esmolol, verapamil. Chronic therapy, amiodarone is the drug of choice or digoxin. Alternatives, verapamil. Now, PSBT acute therapy, carotid massage and drug of choice is adenosine IV. Alternatives, verapamil IV or diltiazem. Chronic therapy, propranolol, digoxin, verapamil. Wpw syndrome, acute therapy is DCO cardioversion is the treatment of choice. Alternatives, flecainide, propafenone. Chronic therapy, amiodarone, propranolol. And radio frequency ablation you can do. And for heart block, pacemaker or injection atropine, isoprenalin while waiting for the pacemaker. The ventricular extrasystole, if asymptomatic, no treatment is required. If symptomatic but patient is otherwise healthy heart, in that case, sedatives like diazepam, alprazolam, propranolol may be given. Developed after acute myocardial infarction, then lignocaine IV. Persistent ventricular ectopics, propranolol. Now, digitally induced, then it is lignocaine. Ventricular tachycardia, acute therapy, Lignocaine is a drug of choice or DC cardioversion. Alternatives, amiodarone, mexiletine. Chronic therapy, again amiodarone. Alternatives, propranolol, sotanolol. Ventricular fibrillation, electrical defibrillation. Alternatives, lignocaine, amiodarone. Deuterium. Now, chronic therapy, implantation of ICD, alternatives, amiodarone. To assert the point is acute therapy, magnesium sulfate IV, isoprene IV, or atrial pacing. Chronic therapy, propranolol, or implantation of ICD. And lethal is induced cardiac arrhythmia, lignocaine, phenytoin sodium, propranolol, and potassium chloride if there is hypokalemia. Injection atropine IV in case of bad arrhythmia. Now, thank you all. Long live our IPS, West Bengal branch, and All India branch. And let us continue with this type of topic again in future. Thanks to all the IPS members for organizing this thing. Thank you all.
Thank you, sir. Thank you very much, sir, for this wonderful lecture. We are really mesmerized by your lecture, sir. So may I request now Professor Susanta Bandyopadhyay, sir, and Professor Santanu Tripathi, sir, to make their comments. And there are some questions in the chat box also. We can address those questions.
So good evening, everybody. It's really pleasure to listen Govinda after a long time. And in fact, I was listening throughout. I missed initially 5 minutes due to the link failure and something like that. And what I realized, in fact, he has covered everything. They're starting from pathophysiology, pharmacotherapy, and the present drugs that are used, and of course the uses and interactions, drug interactions, which is the most important, because once we go through this management, we always feel that there must be some problem or other, including the interaction and as well as adverse effects. Every time monitor treating it, it appears normally that treating arrhythmia is very simple, but it is never very simple, and you never know when you will have to change one drug from the other. We will have to switch over. So you'll have to learn this thing, that as a clinician, that when at what point of time we will switch over from particular drug to another drug, because any drug can cause any kind of adverse effects and reactions at any point of time. But I will not take much time, because already Govinda very nicely he has covered almost everything. It is very difficult to cover up arrhythmia in one class. Santanu, I believe you are all right now, because
Yes.
Asha.
I
Because
am there.
no, that I'm seeing you. I'm happy to see you. The thing is that whomever I am talking, I'm listening that he is positive, he or she is positive. So it's a very severe condition. Anyhow, but at the same time, I congratulate Shambo for organizing at this hour, at this stage, this kind of discussion. Particularly, I have seen the participants, and I believe the most of the participants are perhaps post-PGTs. This is a very significant point to me, and it simply shows that the PGs are interested to learn, to know, and to learn from the teachers of now. Yesterday, we are all now become almost not Santanu, but Ravinda and my now teacher of years. So it's an excellent endeavor on your part, Shambo. Carry on, go forward, and we will be there. We will try to give you support as much as possible in future. With these few words, I hand over to Santanu for his comments. Thank you very much.
Thank you very much, Sushantada. And I must congratulate Dr. Chatterjee, Rovinda, for the wonderful lecture. It was very exhaustive, but at the same time, very lucid. I am sure that all the listeners, they must have benefited a lot. I understand there are a few questions, but then again, let us also look into it that the session does not prolong unduly. So why can we not follow a model that all the questions we can accept through, say, mail or through WhatsApp to Dr. Shambo or the organizer, whosoever are, and then before the next session, the questions will be sent to the speaker, and the appropriate answers would be forwarded to all the listeners. So I think that could be a better this thing rather than now again starting the questions. It will take another 40-45 minutes or 1 hour. So, and the speaker is already must have been exhausted with more than an hour of lecture. So I again profusely thank Professor Robin Chatterjee for such a thoughtful and made the complex topic into so simple and easy to digest and easy to understand. And if Dr. Chatterjee agrees, this has been recorded. But I would request Dr. Shambo, before you can make this circulated, you have to take permission of Dr. Chatterjee, that whether or not it can be circulated widely. But I would say that the questions should be welcomed. All the questions, all the people who have put their questions, Dr. Shambo can collect them and send them to Dr. Chatterjee, so that appropriate answers can also be forwarded to all the people who raise these questions. With these few words, I thank everybody. It was a great success, very beautiful way to start a series of academic exercises, and the right person has actually opened the innings, and I suppose that the coming sessions will be also equally interesting and useful. Thank you again, Professor Chatterjee, Professor Susanta Banerjee, Professor T K Mondal, Tapan Kumar Mondal, and Dr. Shambo Samrat Samajdar, who are the leaders in the West Bengal Indian Pharmacological Society chapter. And hopefully in coming months, we are going to experience more and more academic sessions like this. Thank you again. Over to Dr. Shambo.
Thank you, sir. Now I just request our delegates who had put their question, you please send those questions in the chat box that has been given, WhatsApp chat box, so that we can collect those questions, and then we can put it to Professor Rabindranath Chattopadhyay sir, and then we will collect the answers and we can send you. And may I request Professor Rabindranath Chattopadhyay sir, whether you agree to make this recorded to be available for all the participants for future use also. With your permission, sir, we can only do that.
There is no objection. It is only my knowledge will be at least passed to some others. That is the motto of my life.
Rovinda, I raised this issue because I heard that you are writing a book. So that's why I raised this issue.
No, let it be. Because in my book, some exhaustive are there. I have given the gist of this thing.
Right. Okay.
Because we have to cover up in 1 hour.
So nice of you. So nice of you.
Thank you very much, sir. Thank you very much, sir. So may I request now Professor Tapan Mondal, sir, to say a couple of words.
Thank you, Shambo. I, on behalf of IPS West Bengal branch and from my own behalf, I really extend my sincere thanks to our Professor Rabindranath Chattopadhyay, Robinda. He has deliberated the lecture in nice way. The teacher, actual teacher who teaches us, and that should be like Professor Rabindranath Chattopadhyay. So this is the vast chapter, and he has expressed his all experience, all teaching, etc., within 1 hour, and just comparative efficacy, comparative adverse effect of each and every drug. So really, this is the character of a good teacher. And I have seen also Robinda as a teacher in my university as a guest teacher for 3 to 4 years. And he was loved by each and every student of our university also. Robinda is not the guest teacher or guest speaker. He is the active and also dynamic member of Indian Pharmacological Society and also the West Bengal branch. He was the past president and he hold the treasurer post for a long time. So he's the dynamic person in our branch of IPS. So again, I am thankful to all the delegates and all the senior, particularly Susanta, Tripathi. So this is the brainchild of actually Professor Santanu Tripathi to organize such type of series of your lecture for the PGT. And I am really thankful to our General Secretary, Shambo, for his dynamicity to organize this type of program. Thank you all.
Thank you, sir. Thank you. May I request now Professor Lopamudra Choudhury is there. Madam, do you want to say something? Madam is our Vice President of Indian Pharmacological Society West Bengal chapter. So, Madam, do you want to tell a couple of words? Okay, I think there is some issue. So once again, I am really thankful to Professor Rabindranath Chatterjee, sir, for giving us time. And as we were talking like that a few days back, when just calling sir, Chattopadhyay sir, that most probably in the 12th January, the Swamiji's birthday. So actually it was a dream. Sir was telling like that how I can do this type of electronic teaching, web teaching like that. So and we have some discussion. So actually Swami Vivekananda has a dream. He told that to reach, the school should reach to the houses. And now this type of web teaching actually fulfilled his dream. So we now teachers like Rabindranath Chattopadhyay sir and his class can now reach to the home of us like students of pharmacology. So we really grateful to this commitment, sir. And also I am really thankful to iNovocare E-Academy, Mr. Rohan, for giving us the opportunity to have this season so smoothly. And we are really hopeful on behalf of Indian Pharmacological Society West Bengal chapter that we will get your help in our future endeavor too. Thank you once again, everyone. And we are really planning for next session. Let's fix it and we can tell you in later. So may I request now Mr. Rohan to say a couple of words and we can say goodbye to everyone.
Thank you so much, Dr. Samajdar, for allowing us to be a part of this great initiative by you. Thank you so much, Dr. Rabindranath Chattopadhyay, sir, for your great lecture. It gives us a lot of honor to be allowed to be a part of such enlightening sessions regularly. Hopefully, we can, as we have promised before, we can continue not only these sessions, but also take these sessions forward in some other form and be available to the people on a larger basis. So with that, I would like to invite those of you still present that we have a GCP training program tomorrow. Anyone interested is very welcome to join and connect with us via the WhatsApp group. It will be a one-day event, one-day session with a certificate course. With that, I would like to bid everyone a very happy new year and thank you so much and very good night. Thank you, Dr. Samajdar.
Thank you once again. Thank you, Professor Rabindranath Chattopadhyay sir. Thank you, Professor Susanta Bandyopadhyay sir and Santanu Tripathi sir, and also Tapon Mondal sir. Good night. Good night.
Good night.